It's a 20-year-old male. He suffered a road traffic accident in 2022. He had a catheter at that time. 3 months later, he had developed poor flow and subsequently was diagnosed as stricture urethra and underwent augmentation urethroplasty in July 23. VIU was again repeated in March 24 and May 24. Now he has been planned for redo urethroplasty.
Dr. Bhautej?
Yes. Good
We're
morning.
now live with you, sir.
Yeah, good morning all.
Good morning, Dr. Bhautej.
Good morning, sir. Good morning, sir. So this is actually a case of a redo urethroplasty where there was a buccal mucosal graft urethroplasty performed. The maybe a traumatic or it could be a idiopathic stricture, we don't know. But in the case records of the previous surgeon's notes, it was written as dorsolateral mobilization and dorsolateral BMG augmentation. And he had 2 failures of VIU, so we had planned for a redo buccal mucosal urethroplasty. When you see the surface marking of the stricture, this is the surface marking of the previous surgical site. I gained access through the perineal wound through this previous surgical site. Okay. So this is the landmark for the distal extent of the stricture, where my Nelaton catheter, a 14 French, is just stopping here. So this is the distal extent of the stricture. I don't know the proximal extent. So what I did is I marked my distal extent and I put around a 2 centimeter incision of the skin, a 2 centimeter distal to the distal extent of the stricture. There is a lot of fibrosis. I have marked my inferior pubic rami. This is where the pelvis, the bulbar urethra is dipping into the pelvis, and this is the inferior pubic rami. This is the surface marking of the inferior pubic rami. So coming to this could be a distal urethral stricture, though there could be some bulbospongiosis which is fibrous here from the previous surgery. So we may expect some adhesions and to the surrounding distal bulbar urethra. So most probably I will try to dissect the urethra first, delineate it properly, and then plan whether to do a ventral approach or a dorsal approach. Ideally, this area, especially in the distal bulbar urethral region, most probably it could be a dorsal approach. Once we mobilize the urethra, we will see how to proceed.
Is there any means to find out if we don't have a record, seeing at a RGU, that which approach has been done before?
Yeah. According to the RGU, I still feel there could be a small patch which has been placed, and it could be maybe they must have transected and put a patch. That was what I may understand. According to the RGU, it's a very short segment stricture, but we don't know. There was almost a stenosis within 6 months, so we don't know what was the technical difficulty which previous surgeon faced. We don't know. So that is the idea. This is a short segment stricture.
But many a times, if it has not been put properly up to the normal urethral area, there is a chances of restenosis.
It could be one reason, and they must have transected, and they were not be able to get an end-to-end anastomosis. So they must have augmented anastomotic urethroplasty with a dorsal onlay buccal mucosal graft. That also could be a done in the previous surgery. Maybe that could also be one option.
That
which
is
has been
very
done.
unlikely. It is such a small segment. So whosoever open would able to mobilize the two ends.
Yes, but it was actually in the distal extent. The surgical over the surface marking, it's really distal to the inferior pubic rami. So that's what I feel, that it could be a distal bulbar stricture. So I'll just dissect this part, because seeing here, this is the bulbospongiosus distal extent. This is the distal extent of the bulbospongiosus muscle. So it's almost here. Here there is the bulbar urethra, and this is the distal extent of the stricture, surface marking. So hopefully I will try to mobilize the distal segment and then go proximally, identify the scarred urethral plate, see what can I do. Then if possible, I'll do a dorsal mobilization. There could be some problem. I may have some corporal injury here. I'll try to minimize that by little bit of meticulous dissection. Once I find it, I'll try to open the given incision dorsally. So I'll try to mobilize the urethra first and then proceed. Any comments, please?
Yeah, Bhavtej, this is Deepak here. I think we are clear on your plan, what you're going to do, and we'll see once you expose the urethra, what's the best kind of repair you can do.
Yes, Dr. Bautaj.
So I had difficulty in identifying how to separate. There was no differentiation between the bulbar urethra and the corporal bodies. So this was the scenario. So what I did is, one of the step in Kulkarni's pan-urethroplasty is to invaginate the penis. So you need to do that. This is a very advantageous technique. So I use that technique most of the time, especially in distal bulbar stenosis or distal bulbar redo urethral strictures. I invaginate the penis, I go a little bit up to the distal penile, proximal penile, and then I'll come back down to see there is demarcation between the distal aspect of the bulbospongiosus muscle and the distal bulbar urethra. So that is the reason I went little distal, and I was able to get a plane from the corporal body. So obviously, whenever you do a redo surgery, go from the normal planes to the scarred planes or the surgery site. So that is what I did. So I mobilized the urethra. One side mobilization was done. I was able to identify the urethral lumen. I had small opening somewhere here. I'll just find out. So there is an opening. I removed the graft also with the tissue. I will refashion this area. The dorsal urethrotomy, there is a thick forceps. Can you give me a forceps, DBK? This is the normal urethra. Okay? This is the fibrous urethral plate.
He is not yet open.
So I will remove this segment, which is actually a fibrotic segment, and refashion the urethral edges, and I put a dorsal graft. If there is a very narrow urethral plate, I may actually put one more graft on the urethral, in the ventral urethral plate also, but I need to dissect little further to see what is the proximal extent of this stricture in relation to the inferior pubic rami, so that I will minimize the dissection on the bulbospongiosus muscle, and the proximal bulbospongiosus muscle can be left intact, so we don't need to do anything to that. So I'll try to mobilize as much as possible until I'm confident enough to say that this is the normal urethra.
Bautaj,
Yes.
do you want to go more proximal?
Yes, from here I'll try going proximal, sir.
Yeah.
But I'll do centimeter by centimeter till I identify the.
Tej, if you find it is a very short stricture,
Yes, sir.
then what are the options? Would you consider doing a stricturoplasty?
In a redo urethroplasty, it's always not to transect because we don't know the status of the previous surgery. So I would just do a stricturectomy here, and I'll try to anastomose the ventral urethral plate if I can get this one, and put a graft in the dorsal aspect. Again, I'll repeat, I will remove the stricture segment, which is a fibrous part. I will see the urethral plate. If I am able to approximate end to end here, like an augmented repair, I would do it, or I would put a graft here and I approximate a dorsal onlay, and I put a ventral inlay graft.
Supposing it's a very short stricture.
I cannot,
It is a very
the
short
volume is little less.
I said it is a very short stricture. Would you consider doing a henicumiculis kind of stricturoplasty?
Not in a redo urethroplasty, sir. Redo urethroplasty, I will just do a.
On the other hand, in a redo urethroplasty, for the simple reason that wherever you're going to put the graft is going to be an unhealthy bed.
Yes, sir.
So why not?
If it is a redo urethroplasty, I would see, sir. I would try to do I'll resect this area and then do it. If it's a short segment, but the fibrosis is through and through, almost. So I'll just see how the fibrosis and then plan, sir. If it's a short segment, I would do it, sir, even if it's a redo.
Mandi kind of procedure.
Yes, sir, we can do it, sir.
That is exactly what I'm saying. Just
You can do it, sir, we can do, sir.
without excising at all.
No, sir, no, sir. If there is a lot of fibrosis like this, no, sir. In a redo, no, sir. In a primary, we can do, sir.
We would do it in a primary case. In a redo case,
No,
there
sir.
may be a tight ring, maybe.
It's not possible, sir.
On the other hand, wherever you put a BMG is going to be on unhealthy tissue. It would be better to do a stricturoplasty.
In a redo, I would not prefer to do a henicumiculis procedure, sir. But in a primary case, I would do, sir. Not in a redo, sir. We can do it, but I would not prefer to do it, sir.
stitch the second layer? You know, it is said that you don't do mucosa to mucosa.
Mucosa to mucosa? I'm doing mucosa to mucosa only, sir.
No, but yesterday
I'm
I
not
think Dr.
fixing-
Kulkarni was saying that mucosa to spongiosum. What is the rationale for that?
No. I'm not. I'm taking the wide. The plate is wide, so I'm taking mucosa to mucosa only. But what I do is I don't take apical sutures or the disc. I take 5 apical sutures, 1, 2, 3, and that's it 3. I don't fix this to the corpora. The same thing, I don't fix the distal, proximal 3 sutures to the corpora. I have done, nothing is fixed. Only from the distal 1, 2, 3, then later I take the corporal stitches. So it just, just to prevent some anastomotic strictures or distal rings, I don't fix this one to the corpora like that. So let it breathe, let it move, let that distensibility be there. So that's the reason I just fix 1, 2, 3 without the corpora. So it will be loose. From here I start with the corpora. So this will prevent, at least to my extent, my experience or whatever we have seen in the follow-ups, I changed my technique by not putting these 4 or 5 sutures, 3 side, this side and that side 3 sutures, to fixing it to the corpora, so that it will at least distend in that area. But the graft is going to be fixed. It's not going to be a problem. So this is one way where you can prevent any distal or proximal anastomotic rings. So you have the bulbar urethra or the distal segment will distend with when the flow. Once you fix it, then if there is fibrosis, obviously whenever you take a suture, there is always a fibrosis. There's chance of more fibrosis and stable distal or proximal ring which forms. So this can be done to prevent any distal or proximal rings. So we
A question
have
for
followed.
Dr. Murthy, sir.
Yes.
Bhavatej,
I can't hear you, sir.
Dr. Bhavatej,
Dr.
Yes,
Murthy.
sir. Yes, sir.
that is the fixation I would suggest. That is what you are taking underlying tissue, edge of the mucosa, then edge of the urethra. So
Yes.
that will fix the graft. It will be more stable, that segment.
No, I won't do it to the distal and the proximal segment. The rest I will do it, sir. That's what I am saying. Not at the level. Anyhow, we are going to, it is going to be dorsally. So it's almost going to take up. So I will just fix the periurethral tissue a little bit, loose, or I'll just leave it alone. With the recurrent strictures, I'll just leave the periurethral tissue also. I won't fix any periurethral tissue also. Just leave it like that.
Question
Otherwise-
to Sanjay. Sanjay, are you here? Yeah, you are quite a vehement critic
If
of
there is no
taking
urethral-
the mucosa to mucosa on the lateral side. Any particular reason? Because everybody wants to know the same thing.
Mike 2. Mike 2.
What happens if there is a mucosa to mucosa anastomosis?
So basic idea of a dorsal only buccal mucosa urethroplasty is half the bulbar urethra is supposed to be 30 French, half the circumference will come from buccal mucosa which is 15 millimeter, and you have a urethral plate which is 7 millimeter. Okay? How can you marry 7 to 15? Not possible. On one side you do mucosa to mucosa, other side you do mucosa to spongiosa. All right. Unless like here we have a wide urethral plate after, because this is a narrow stricture. He excised the scar, he did mucosal anastomosis, and the rest of the urethra looks okay. If it is 15 French, then you can do mucosa to mucosa on both sides.